super excited to be here. I am so pumped to get to discuss today with the one and only Yusuf. And so, Yusuf, do you want to say hi to everyone?
Yeah, hi everyone. Sharmin, I've heard your voice for like 8 years now, but I'm first time we're co-discussing together, so I'm so excited.
I am beyond excited, my friend. It's been so fun to record schema episodes with you. So I'm glad we get to do this as well. Big shout out to Julia for doing Teaching Point and for Swanson for doing scribing. We have an awesome case presenter. Sohail, do you want to say hi?
Hi everyone. I'm
Uh,
so
yeah. Can you tell us a little bit about yourself?
sure. So I'm currently a fourth year medical student in San Francisco, um, and love clinical problem solvers. I've been here since actually not too long. I've been here since March or April. In my free time, let's see, I like anything aviation related.
Nice. That is very, very cool. Thank you so much for being here and for presenting. We really, really appreciate you. So if we can get the board up, we can get started. All right, Sohail.
Okay, so this is let me see how many aliquots. I think there's five aliquots, and the fifth one will reveal the diagnosis. So, so we have a 28-year-old male who presents with diarrhea and abdominal pain, and HPI on admission reports that diarrhea worsened the day prior to admission, about 10 bowel movements per day. Describes stool as watery, loose, yellowish brown, no blood. He has been taking his Lomotil and Imodium without adequate improvement. Currently, his concern is 7 out of 10 diffuse, dull, non-radiating abdominal pain that has been intermittent since day prior to admission. The abdominal pain is refractory to pain medications. He has nausea, but no vomiting, and he has been able to take his oral medications and some fluids, but little food. And I'll stop there for the first aliquot.
Thank you so much, Soham. What a interesting case with an explosive start. So, in general, when I think of diarrhea, there are many ways to break it down. I know there's you can break it down by acute versus chronic. There's other people who break it down by is this localized to the small intestines versus the large colon. Another way to break it down is this osmotic or inflammatory or secretory. But even before we go all down that rabbit hole, like to start with, is this acute or chronic? And should we even name the problem diarrhea, or should we focus more on the abdominal pain? Diarrhea is very, very non-specific. For example, 30% of pneumonias are associated with diarrhea. And a lot of times it's not necessarily the center point of unlocking the case. But in this case, the associated symptom is abdominal pain, and we don't see any other associated symptoms so far as of yet. So I do want to focus on that as like a potential like focus of this case. And it sounds like it is acute. So I would want to know from you, Soha, like, has this been going on before? Is this the first episode, or has this been episodic, or is this the first time it occurs? But if it is actually acute, I would think of, is this the first presentation of something like autoimmune, or is this like more likely like an infection that is very, very common? Because in all comers, if you see anyone with abdominal pain and multiple episodes of diarrhea, my first thought would be enteritis, none otherwise specified, and we don't even always identify the organism. This would be like my general thoughts, but I think we can go to more like specific diagnoses when when we have more information. What do you think, Sharmin?
No, I 100% agree. That's how I like to think about it too, whether it's like acute or chronic, and The one caveat is like chronic diarrhea has to start sometime. So I think the initial presentation of a chronic diarrhea is often acute. So I think like as we get more workup and more information, it would that especially with the studies, I think that can help illuminate which bucket we're dealing with. I thought the questions that often help me is, nocturnal diarrheas. It's like kind of helps you if they have to like wake up and go to the bathroom at night versus like that's less likely to be like kind of food related as well. So yeah, I think with the diarrhea, the more I take a patient with the diarrhea, the more like a really good history is very informative. In terms of like, if we are dealing with like an acute diarrhea that has started a day, especially in a young adult, oftentimes, we think about like ruling out infectious etiologies. And with infectious etiologies, I think one thing that is often helpful is a kind of travel related. If you had any recent travels, then oftentimes like, you want to think about like more bacterial causes of it. Like toxin related is another one to think about. And again, and someone who's 28-year-old coming in, that one other thing that I would want to make sure to know is like HIV status, because that again can even further broaden your diagnosis. But as Youssef mentioned, I think it is a bit too early. I loved your discussion about the abdominal pain versus the diarrhea, is that one can be the other one. So keeping both in the forefront, so thinking is it something yes, and whether they're one against the other, like meaning like, oh, is it the diffuse diarrhea that is the actual problem that has caused the abdominal pain, or is that something going on with the abdomen that is causing the diarrhea as a consequence of it, like a ischemic colitis, for example? So I'm super excited to hear more, Sahil.
Thank you. Starting with the past medical history, he has BALL. In November 2023, he had an allogenic hematopoietic stem cell transplant complicated by CMV viremia. This was treated with valganciclovir. In December 2023, he had a facial rash, vomiting, diarrhea. He was then found to have graft versus host disease from sigmoid biopsies. Symptoms improved during the hospital discharge, and he was discharged on steroids and tacrolimus. Family history was reviewed and non-contributory. Smoking history, no smoking, alcohol, or drug use. Allergies or no known drug allergies. For his prophylactic medications, he's on acyclovir, atovaquone, levofloxacin. And for his immunosuppressive medications, he's on budesonide, prednisone, tacrolimus. And I'm sorry, I forgot to put the review of systems. So let me go through that and let me go backwards here. For ROS, he had malaise, fatigue, and a weight loss, with a 20-pound weight loss since last year, with reduced appetite, abdominal pain, and diarrhea. He also has nausea. All other review of systems are unremarkable. He did have some baseline migratory arthralgias in his knees and elbows since last year, but that's it. That's the end of this alpha.
All right. Wow. Now comes the graft versus host disease. So, I think in terms of the rest of the review of system, again, it kind of goes with the picture that is getting pictured. Someone is having a lot of diarrheas, and I'm inclined to think about like the malaise, fatigue could be isn't associated with whatever is causing the diarrhea, especially if we're thinking about more like inflammatory etiology of it. And I think in terms of like the weight loss, we know this is someone who has had an underlying malignancy, and I think that is something to keep in mind. Because like one day of diarrhea, you wouldn't associated with weight loss. So as we're going through the case, whatever the final diagnosis is or whatever workup we're doing, should we keep in mind there's someone who is having a significant amount of weight loss. And in terms of like the migratory arthralgias in knees and elbows, so, in terms of like, again, like kind of pointing a picture of, I wonder about like inflammatory conditions, whether like infections or autoimmune. And I think with the migratory arthralgias, like an exam would be helpful if you're doing with an arthritis or not. In terms of the graft versus host disease, so oftentimes I think about like graft versus host disease, whether it's like acute or chronic. Acute tends to be, I think nowadays, a lot less common because of the way the bone marrow transplants are happening. But within those findings, sounds like he did have oh, sorry. Sahel, can you remind me what complications of graft versus host disease did he have? I don't think I caught it.
Sure. So he had facial rash, vomiting, and diarrhea.
Wonderful. Yeah. So yeah, the skin findings tend to be the most common features of acute versus host disease, but again, it's a systemic disease that can affect multiple different organs. Oftentimes people can have intrahepatic cholestasis, diarrhea. Oftentimes I think it's like a secretory diarrhea. It can have lung findings in the picture of like a pneumonitis, and renal as well. So it can cause a lot of itises as well. So knowing that this patient in the background has had this before, and a lot of times like with the chronic graft versus host disease, and with acute, if we're dealing with like a relapse of these symptoms, I think is like a worthy consideration. Then I'll pass the mic for the meds, and curious to hear your thoughts, Youssef.
Yeah, I think this is very interesting very quickly. With the steroids and the mycophenolate, I usually think of defects in the neutrophil function and as well as the T cell function. In general, if you have defects in the neutrophil function, you're more likely to get extracellular organisms like normal flora, candida, molds, or even C. diff. But if you notice, all of these tend to be very acute. However, the T cell defect with the mycophenolate makes me think of intracellular organisms. This includes endemic fungi, like viruses, mycobacteria, and these tend to be more subacute to chronic. And it sounds like we do have a history of a subacute picture here. The other things to think of are like the mycophenolate itself can cause a side effect, which is diarrhea. And then CMV, the patient has already had a CMV viremia, which was treated with acyclovir, and seems like they're on prophylaxis. But that is a possible side effect as well of the T cell immunity being down. A lot of times my interns will ask me like, oh, should we get a CMV PCR or an EBV PCR, for example? And my answer is it depends on the host. So if the host is not immunocompromised and does not have the right syndrome, then I do not recommend getting those levels unless you really think it could be it. But in this case, for example, a patient is immunocompromised and they have a right syndrome of a question mark colitis, then I would potentially get like a CMV PCR eventually after the exam and imaging, or if there's a concern for colitis, for example, although the ultimate diagnosis is through tissue. Other things to think of are graft versus host disease, like you mentioned, and these are my general thoughts. So eager to know more. So
Yes. So on ED admission, the patient had a temperature of 36.9, heart rate of 74, blood pressure was 131/89, respiratory rate was 18, and O2 sat was 98% on room air. On exam, the general appearance, ill appearing, but not in acute distress. He was normal cephalic, atraumatic, moist mucous membranes. For his cardiac exam, regular rate and rhythm, no murmurs. Pulmonary, normal effort, no wheezing, bronchi, or rales. abdominal exam, soft, non-distended, but he had positive diffuse tenderness with no guarding. MSK exam, there was no joint swelling, tenderness, or deformity. The skin was warm and dry. And for his neurologic exam, he was A&O ×4, no focal or gross deficits. And I can go into some of the basic labs. So for his hemoglobin, he had a hemoglobin of 12.5, a white count of 4.2, platelets of 149. His BMP, his sodium was 130. His potassium was 4.1. His chloride was 99. His bicarb was 23. His BUN was 10. And his creatinine was 0.78. His glucose was 134. Some of his LFTs, his AST was 21. His ALT was 7. And his alk phos was 71. His T-Billy was 0.8. I'll pause there.
I'm gonna start with the exam, Sharmin, and then I'll give you the labs, although I'm not sure there's a lot to go off on. In general, if you listen to the last subspecialty session with Dr. Fatke, he was one of the attendings I had on transplant ID. But all of our guards and exam maneuvers are different in a patient who's immunocompromised as opposed to someone who is not immunocompromised. Because patients who are immunocompromised might have more disease and exhibit less symptoms. So a patient might have, in this case, non-distended diffuse tenderness, but no guarding on exam, but the underlying disorder might be more severe or grave. So just by the fact that the patient has diffuse tenderness on exam, I would have a lower threshold to get a imaging of this patient's abdomen just because they're immunocompromised and they're having this syndrome. I'm glad they're afebrile as well, but again, because they're immunocompromised, I have a lower threshold to rule out infections, and I would still think of infections. But that's how I would think of that exam. Sharmin, what do you think?
Yeah, no, for sure. I think coming in with abdominal pain, a significant diarrhea in someone who has a complicated course with their underlying malignancy, definitely. Tube of truth, I never say no to it. And I think, yeah, and it's also interesting, like, what is not present, right? You know, we in terms of like we don't see any rashes, we don't see anything else of like any arthritis on the exam either. So it just seems like it is, for now at least, from the exam, that is kind of the problem is like localized to most likely the GI tract at this time. And I think like the labs in a similar fashion, right? We don't see any like pancytopenia. His electrolytes are doing good, which kind of tells me if somebody's having like a psychosis diarrhea, 10 bowels, not being able to eat and drink for a long period of time, I would expect some presentation in their labs, in their electrolytes, in their creatinine. And it kind of tells me that like at least this bout, as reflected in the history, is quite acute, that he hasn't had developed any long-term complications of the acute diarrhea, especially when it comes to alkalosis, thinking about hypokalemia, thinking about like AKIs. So we're probably catching him in the right time to prevent those from happening. In terms of like, again, the liver labs are also normal. Again, we weren't really getting a flavor of a hepatobiliary etiology. So worth noting. Again, I agree with you. I think this is someone that And imaging would be helpful, although oftentimes I feel like I get an imaging and it's just colitis, and then I'm like, okay, what causes colitis? So, but I think it's helpful, especially I think if there's any other lymphadenopathy, any other imaging finding that makes us broadens our lens of whether this is just a luminal issue or is this part of a bigger issue. Because with the review system, and with the weight loss, we were worried that this is perhaps a more like systemic issue. So I think that would be very informative to see if it's just localized to the luminal tract. And, I think the hard part with people who have had underlying malignancies who are coming in with immunosuppression is that the rule to path any diagnosis is to rule out infection. And oftentimes the infection buckets can be so huge. And oftentimes I have like a low threshold, especially with patients who have come in with acute diarrhea, to get our GI colleagues involved. And oftentimes, as you mentioned, tissue is the issue because some of these PCR characteristics are not as good. So that is kind of where my brain is getting the imaging, getting the stool studies going, and and as you mentioned, being immunocompromised just broadens that lens of viral, bacterial etiologies of acute diarrhea. Also, C. diff, out in the community is getting more common. So sending a C. diff test as well is where I would be going with that. The other thing in a young adult, always they think about getting a good sexual history as well would be helpful, in addition to the HIV testing here as well. So that's where my brain is going. I'm excited to learn more, Sahil.
Thank you. So I'm going to give some advanced labs and imaging. So the bacterial, viral, and parasitic stool PCR studies were negative, and I just wanted to say that the components of the bacterial panel that we tested for were C. diff, Campylobacter, E. coli, O157, E-tech, S-tech, cholera, Salmonella, Shigella, adenovirus, rotavirus, and norovirus. We also tested parasitic, which include Cryptosporidium, Entomoeba, and Giardia. CMV DNA titers were positive. And let's see, some imaging studies. So the CT abdomen and pelvis, there was wall thickening, edema, and hyper-enhancement of the entire colon. There was no free air or drainable fluid collection. We performed an EGD, which I have images of the EGD and the colonoscopy. Actually, I only have the images of the colonoscopy, which I can share with you through PowerPoint. EGD was grossly normal, and the colonoscopy, okay, thank you. Let me share the images of the colonoscopy, and then I'll give you the associated report as well. Okay. So here are the colonoscopy findings.
Thank you, Sahil. Is this the end of this aliquot?
I can give you the report as well that was associated with the colonoscopy. So the colonoscopy was severely edematous, ulcerated mucosa circumferentially throughout areas of examined colon, proximal descending colon and sigmoid in particular. Less than 10% of the mucosa was normal in this area. Healthier, although still erythematous rectum. possibly pseudomembranous colitis, although hard to definitively say if pseudomembranous or just very severe colitis. Procedure was aborted given risks of perforation. And so the procedure was only done up until the descending, halfway through the descending colon. And that's the end of this aliquot. The next aliquot will reveal the diagnosis.
Sharmin, is it your turn to go first?
I think it's you, my friend.
Oh, okay, perfect. I think Sohail, this article was very, very rich in that you gave us all the lab tests in the order that we would have done in the hospital. Realistically, like the tier 1 tests in someone who's immunocompromised are always going to be a C. diff, in this case, CMV PCR, and a stool PCR to look for common pathogens, because that would be like a quick reversible finding that you can quickly treat. In this case, we see that the stool, the PCRs and the C. diff were negative, but the CMV DNA titers were positive. And we were just talking about this before. They said, oh, what do we do with a titer? But in a patient who has the right syndrome and the right immunosuppression, I think this increases the likelihood of having CMV tissue invasive disease. So I just pulled up the guideline, and according to the guideline, if the CMV PCR is positive, you start empiric therapy and then do a colonoscopy. That's how high the likelihood is, especially if they have the right syndrome. So in this case, exactly like you all did. So we have the positive CMV. The next step would be to do a biopsy and to rule out other causes. I see the colonoscopy was done, and we see the classic ulcers, which in my mind immediately goes to like viral etiologies, like herpes, CMV, and things like that, to rule it out. I know like the tissue sampling will also like give us the specific diagnosis to tell us if this is CMV or whether this is immunologic. But in my mind, we would like start empiric therapy now, and then while the tissue comes back, and that would be where my mind is. And what do you think, Sharmin?
Yeah, I think it's hard not to think about CMV given the prior history, even though yeah, I think there's definitely been cases, even with acyclovir suppressive therapy, people still developing significant ulceration and CMV colitis. So for sure, I think like empiric therapy is warranted. Also, like thinking about what else could cause ulceration, and also like whenever I think about more rare diseases that I just don't have as much experience, I don't know, like in terms of like graft versus host disease, like what would be the colonoscopy finding. Actually, I have no idea. So that's something that I would look. Does it have any component of ulcerations, like PTLD? Does that have a component of ulcerations? I do not think so. But again, like I think thinking about like the gaps in knowledge, empirically treating for CMV colitis at this point, and also at this point, realistically, I would be kind of looking into some of these other etiologies that I'm less familiar with to make sure I'm not missing a double hit model or another reason. The other thing is also like the treatment is your diagnostic test of patients getting better with the treatments, then you have your answer that, well, perhaps we're in the right path. But if the patient is like also not improving as you would expect once the correct treatment is initiation, is another good time to pause and reflect, like, are we missing something else in this patient? I think especially as you mentioned, kind of with being immunocompromised, infiltrative stuff can happen too. So yeah, I think the biopsy would be key. I would treat empirically for now, and then see what we find. Any other thoughts, Youssef?
Nothing to add.
Wonderful. All right, Sahel, what happened next?
So, so the final aliquot. So, we did get stool cultures again, which were once again negative. We got biopsies of the sigmoid colon. And there was no IBD or CMV colitis. It did reveal Staph aureus as the organism causing this colitis. So initially, we started empiric therapy with ganciclovir and acyclovir to treat empiric CMV and HSV colitis, but the patient did not improve throughout the hospital course. We then switched to oral vancomycin, and the patient showed rapid improvement and was discharged following then. And that's the end of that aliquot.
Whoa, I have never seen colitis caused by Staph aureus before. This is amazing. Well, Staph and strep, they never cease to humble me. So thank you so much for presenting. I think like with these patients specifically, anything can present uh, atypically, or like diseases have such different manifestation that what we've learned. So you can never stop looking into it. And I think like choosing your treatment as a diagnostic test is a good clue. Uh, what did you learn about, how did you learn, how did you feel when this test came back, Sahel?
This was really shocking because I've never like, I mean, we typically think of viremia or like CMV virus, maybe HSV and the stool panels, the common organisms that are tested as being causes of colitis. But after the biopsy came back positive for Staph aureus, I did look online. There are very few case reports of Staph aureus colitis in immunocompromised hosts mainly, and people who have taken antibiotics recently. Apparently, IBD also predisposes to this kind of colitis, but it's very few and far in between. Um, and let's see. And I also learned that, as you all pointed out very astutely, negative or positive CMV DNA titers do not necessarily rule in or rule out tissue invasive disease, but that was already talked about. And think, yeah, it was very humbling case.
Yeah, I am, as always, humbled. Yusuf, what are your thoughts?
No, thank you so much for bringing this, Sohel. What an amazing case. Like Mark mentioned, like I've seen maybe Staph 20s of times, tens of times, but I've never seen it cause colitis. So I love when there's an atypical presentation of a common disease because it broadens our illness script even further, especially in immunocompromised patients. So I can't wait to read more. So thank you so much, Sohel, for bringing this case. Julia, did you want to say the teaching points?
Sure. First, thank you so much for this amazing case. I mean, diarrhea is a presenting symptom that we approach many times, and you guys, Yusuf and Sharmin, showed us again how to approach it in a very smart way. So thank you so much for that, and so for this like rare outcome of the colitis, which never and none of us have expected. So thank you for that. First, we discussed how to approach diarrhea, and we were reminded that 80% are infectious, mostly viral, and 20% are roughly are caused by meds. We can also think about the mince and mnemonic. So we're thinking about meds, infection, necrosis, and toxins. And also before we kind of dive in and dissect the diarrhea, we first should think about whether diarrhea is the center of the clinical presentation of our patient, or rather an accompanying symptom. And then we can kind of think about if it's acute or chronic, if it rather centers in the small or large intestine, if it's osmotic or secretory, and also think about the time course. So is this nocturnal, food related, and never forget taking a very deep past medical history. Think about surgeries, diabetes. Next thing that we always have to keep in mind is like thinking about the red flags in presenting symptoms, which would be like bloody diarrhea, weight loss, in immunocompromised patients or IBD in the history when we think about diarrhea. In young patients, it's often an infectious cause, and that's why we really have to focus on travel history. And don't forget to take an HIV status and the sexual history. Our patient also presented with migratory arthralgia, so that can be a hint to inflammation. The next topic we focused on was graft versus host disease. Here we can think about an acute and subacute to chronic presentation, whereas acute is a little less common and mostly presents with skin findings, intrahepatic cholestasis, and secretory diarrhea. Also, there can be lung findings like pneumonitis. Interestingly, patients suffer from a defect in neutrophilic function, and that leads to a patient being more prone to infections with extracellular organisms like Candida. That would be more the acute presentation. When we also think about like subacute to chronic, that can be a consequence of T cell dysfunction, where we then find more often intracellular infections like fungal infection, viruses, or mycobacteria. And don't forget that the medication itself can lead to the presenting symptoms. So mycophenolate can cause diarrhea itself. When you focus on an exam in an immunocompromised patient, we should also don't underestimate the exam's findings, because they can present with less symptoms, even though the disease is quite severe. Lastly, in the biopsy, it reveals that colitis findings, but the CMV was negative, which would be the most common cause of colitis. But there were some Staph aureus found, which is a rare presentation of colitis. But it is a finding we can think about in patients who had recent antibiotics, or in our patients being immunocompromised. Also, in patients with IBD, they're more prone to these kind of colitis. So thank you so much, everybody. I've learned a lot, and I've got to revise and dive into Staph aureus colitis. Yeah, and thanks also for the viral chat, like always. Very great discussion, guys.
Julia, absolutely brilliant friend. Thank you so much for those awesome teaching points. Sohail, awesome job presenting this case. Absolutely masterful. Swanson, thank you so much for your scribing. Youssef, you're amazing, my friend. I love discussing with you. And I think like this case again, like kind of highlights for me the importance of like having a systematic approach, and also the tissue biopsy. And I feel like with these patients, one thing that I am taking away from this is just kind of importance of getting the tissue, because you never, ever know. What a humbling case. I love learning something new, Sohail. So thank you for teaching me something new. Thanks all.
Thanks,
See you
everyone.
tomorrow.